Welcome to In Session, the North Carolina Healthcare Association's podcast where we dive deep into the critical issues impacting hospitals, patients, and the overall health of our communities. Whether you're a legislator, a policy advisor, or a community leader, this series is designed to keep you informed about the challenges and opportunities in healthcare today. I'm your host, Nicholle Karim, and today we're talking about a troubling trend affecting children in our state custody who are experiencing a behavioral health crisis. So imagine this. Children, often dealing with their own mental health challenges and involvement with child protective services, end up spending days, weeks, and sometimes even longer in hospital emergency rooms. Their long stays in the emergency room are not because they need medical treatment, but because there is simply nowhere else for them to go. North Carolina's foster care system, already stretched thin, faces a shortage of foster homes and specialized behavioral health resources. As a result, children end up stuck in environments like emergency rooms or even Department of Social Service offices, otherwise known as DSS, waiting for placements. According to the North Carolina Department of Health and Human Services, 36% of children who arrive at emergency rooms for behavioral health crises end up staying there for 7 or more days. For those in state custody, the median length of stay skyrockets to a shocking 32 days. Data from NCHA member hospitals also shows that most children presenting to a North Carolina emergency department for a behavioral health concern don't need specialized inpatient hospital care. Instead, long-term treatment like residential care or specialized therapies are needed. Joining me today to share perspectives from one of North Carolina's hospitals is Paula Bird, who's the Vice President of Psychiatry and Mental Health Institute at Novant Health. Paula also participates in the association's Behavioral Health Advisory Group focused on finding solutions to improve access to mental health care. Welcome, Paula.
Thank you, Nicholle. It's a pleasure to be here.
It's hard to imagine what it's like for children to live in an emergency room. So can you share with us what a typical day looks like for them?
You know, Nicholle, it's really sad that even has to become a question. No one, especially children, should be living in the emergency room. But to answer your question, there really is no such thing as a typical day. The reality is that emergency departments are designed for temporary utilization. It's really a place where patients come to either be treated or to be admitted for inpatient care. When it comes to children with mental health needs, our behavioral health team certainly does assess patients, and we make sure that we're meeting the acute medical needs of that patient, whether or not it is a psychiatric or mental health condition. And we make recommendations to either admit the patient or to transport them out for an outpatient support. Unfortunately, there's not enough outpatient resources. Foster families or psychiatric residential treatment facilities, also known as PRTFs, that are readily available to always guarantee immediate transfer for those patients. This can lead to prolonged stays, like you mentioned, where sometimes waiting as long as a month in our emergency departments while they're looking for that next level of care that is not an acute inpatient hospitalization. And oftentimes those children are sitting in an emergency bay with a sitter. So it's incredibly disruptive to their daily life, their school routine, but they can also experience feelings of loneliness and sometimes even abandonment. For any child, these feelings are growing concerns. We see this not only for children that are presenting to our ED, but we also know that students and children in North Carolina are really struggling right now. Suicide is the leading cause of death for our youth ages 10 to 14, and 39% of students report feelings of sadness or hopelessness. So it's not just those that are even presenting to our emergency department, but also just the mental health of our North Carolina kids in general.
Paula, you touched on this in your answer about the role of foster homes and also these specialized residential placements like a PRTF. How does the shortage of those resources contribute to the situation you just outlined with kids staying in emergency rooms longer than they should?
Nicholle, it really comes down to supply and demand. North Carolina simply does not have enough foster homes or behavioral health resources within our state to adequately provide the care that our children need. So as a result, too many families resort to needing to come to the emergency department when there is a crisis. While hospitals are here to meet those healthcare needs for our patients, We often find that these children are presenting to the emergency department, but in fact do not have an acute psychiatric need that requires hospitalization. What they need are outpatient services, sometimes intensive outpatient services, wraparound services, but the hospital is not the best place for them to be. We need to be able to develop a network adequacy program that allows families to access those resources outside of the emergency department rather than coming into the emergency department that is so chaotic and can often add additional trauma to that child while they're waiting for that appropriate level of care. These outpatient services are in short supply, and it can take a lot of time for kids to get placed out into the community. So what we see here is that we have a lot of children that are waiting for extensive periods in the hospital, in the emergency department before they can be placed. The state recognizes this problem and is working to address it. In the meantime, we all should do more to raise awareness like we're doing in this podcast.
Paula, it's so troubling to hear. Sounds like the growing trends of children in needing mental health care and not being able to access the care that they need. And I know that our conversation has been focused on kids in foster care, but we also know that it's not just kids in DSS custodies who have these long stays in emergency rooms. It's often children who just have DSS involvement. Can you tell us a little more about that group of children and some of the unique challenges they face?
Absolutely. Like I mentioned earlier on when we started this conversation, with 39% of students feeling sad or hopeless and suicide being the leading cause of death in our children ages 10 to 14, that touches a lot of youth, including those that are outside of the DSS system. So what happens is that we end up seeing kids that may be DSS involved. So the families are really in crisis as well. It's not just the child, but it's their families. They don't know what to do. So they're coming to the emergency department because they feel that they've tried it all and they simply have no place else to turn. And so they bring their child to the ED when they really feel that they have nowhere else to go. And they drop off the child and say they can't come home. I don't know what to do. My child needs help. We need help, but I know that my child cannot come home with me. And that's really where we start seeing that bottleneck as well, because those DSS involved children, then coupled with the DSS youth in custody under DSS, create this bottleneck in our emergency departments where we simply don't have the resources available to quickly find placement for these kids that are waiting to go into outpatient services. Again, we don't want patients to be in our emergency department that don't need to be there. It's chaotic. It can be traumatizing. And we also don't want to admit children that don't have a psychiatric need to be admitted. We really want these children to be in a loving care area where they can receive the best care possible with the services they need. And that is not an emergency department or an acute care inpatient stay. I think what happens too is that families are dealing with these things in isolation. I really think about how sad it is that after 30 years in psychiatric nursing, we're still at this state where people just don't know where to turn and they end up coming to the emergency department because we are that safety net. I think if we could really focus on upstream and really look at how we could better provide earlier intervention with all of our youth, really looking at things really very simple, things such as vital conditions, where we really want to focus on making sure that all children receive proper nutrition, sleep, exercise, and social connections. That's really going to go a long way to helping to keep kids healthy and not getting into that pipeline of needing to get psychiatric care on an ongoing basis.
Yeah, those prevention efforts you just listed seem like a really great way to get to the root cause of some of the issues that we're experiencing in our system and keep kids healthy. Recent legislation impacts care at hospitals for these children. So in October of 2021, Senate Bill 693 was enacted to coordinate services among local DSS, the state Medicaid agencies like the local management entity, managed care organizations, or the prepaid health plans, the hospitals who are involved in this care, and NCDHHS for youth in DSS custody seeking mental health assessments in the emergency room. The law was meant to streamline care for children in DSS custody. What challenges have hospitals faced in terms of the implementation of this bill?
We appreciate the state's efforts with that piece of legislation, and it's helped to keep the issue in focus across North Carolina while we continue to make improvements. We have seen a few challenges in implementing the policies because there simply are not enough resources. We really need to be able to focus on improving the continuum of care And while the rapid response team certainly raises awareness, they're not creating that healthcare continuum as we look to solve this problem. From the hospital's perspective, the bill has helped streamline the assessment and care coordination. But again, it takes time to find those places for children to go. So the rapid response team really does focus on bringing the family, DSS, and the LME MCOs together. And most recently, they're looking to also assure that the hospitals have a place at the table as we're planning to the coordination of care for those children. But the reality is that while the process has been improved, there's simply not enough available resources in our community to manage the volume of patients and referrals. So this creates a delay, and it's really the child who suffers. So for example, we're now able to assess children and complete that care coordination paperwork faster than ever, but the child remains in our care because it may take weeks or months to find a foster family or a PRTF to become available. The sad reality is that hospitals are not designed to provide long-term residential care. And while the challenges are complex, we are moving in the right direction. Work's already started to enhance the services and offerings at existing PRTFs. So this is hopefully going to lead to shorter length of stays for children in those PRTFs that will then create capacity for those children that need to move into a PRTF to be able to do that more quickly. The state's also rolling out new training to equip foster families with the skills they need to successfully welcome a child with behavioral health challenges into their family.
So Paula, I know one thing you and I have talked about, we've talked about in the Behavioral Health Advisory Group, is this new child and family specialty plan that is going to be serving children who we're talking about today who are involved with DSS or in foster care. The state has delayed the launch of this plan to December of 2025. So you've discussed one of the major issues with long emergency room stays is the fact that there is not enough services available. What policies will be important to ensure children get the services they need when they need them?
So once it goes into effect, this plan will help coordinate care for children involved with DSS. But the broader issue we keep coming back to is one of network adequacy. This is an issue facing all patients, regardless of payer or insurance provider. If a clinical expert in the emergency department makes a recommendation for care, we need legislative support to make it so insurance companies don't come back and say that the patient doesn't need that level of care. We need to be able to trust our experts. Bottom line, these children often need wraparound services, and we should be focused on removing barriers to care, including the financial barriers. I think we're moving in the right direction, but we should keep advocating for the most appropriate level of care to be approved and accessible to our patients.
So Paula, looking ahead, what changes would you like to see in North Carolina's foster care and behavioral health systems to prevent these extended stays in emergency rooms?
To start, I want to recognize the work that's already happening in this space. The North Carolina General Assembly included in its 23-25 budget $835 million investment to strengthen the state's behavioral health system. This investment is committed to strengthening our crisis system, opening new behavioral health urgent cares, adding new beds to the community crisis centers, and providing more training for foster families. There's also movement in terms of unifying the Department of Social Services. In North Carolina, our 100 counties have historically operated independently, but the state is in the process of combining each county into 7 regions. This is a move in the right direction, and it certainly will help with the coordination of care in the future. I think more can be done to promote mental health education so parents and families can seek early interventions and have the most effective sites of care readily available to them rather than just the emergency room. Just as you don't go to an emergency department because you have a cold, because there are more appropriate venues of care, such as a primary care physician or urgent care, the same should be true for mental health services. The best way to prevent long-term extended stays in the hospital is to connect children and families with the right care provider at the front end.
What can community members, policymakers, and healthcare providers do to ensure these children have the healthcare and the state child care system supports they need to thrive?
Well, it's important to be involved at a local level. Identify your representatives in the General Assembly and reach out. Lawmakers are most engaged when their constituents respectfully highlight concerns, and so local level outreach is key. NCHA is also a great resource to learn more about who represents you and the information that can be most helpful to elected officials as they make these important decisions. Community leaders can do a lot to help lift the stigma around mental health. Great resources include NCDHHS, NC Department of Mental Health, Developmental Disabilities, and Substance Use Services websites. The 988 Lifeline is also incredibly helpful. This crisis line exists to help children and families navigate mental health challenges. In many cases, it may help them get the care they need sooner to avoid a hospital stay. From a hospital perspective, we're investing in a number of different programs. We have embedded therapists in the MORS pilot program at Presbyterian Medical Center. MORS stands for Mobile Outreach Response Engagement and Stabilization Programs. This is a mobile program that meets patients and families where they are and makes sure that they are connected to wraparound services to allow a child to be successful in an outpatient setting. We're continuing to train our behavioral health access team, and we're working very closely with care coordination with our local authorities and agencies. The other thing that we've done most recently that I'm very proud of is that we've partnered with Katie Blessing Center to develop a behavioral health urgent care that will focus as an alternative to emergency care services that will be serving children 4 and older in the Mecklenburg County area. Very excited about that. And then finally, we are really leaning heavily into telemedicine. 68 counties in North Carolina do not have a child and adolescent psychiatrist within that county. And so by providing telepsychiatry services within Novant, we're able to reach a larger number of children across North Carolina that otherwise would not have those services available to them. So very excited about all these programs that we're doing and investing in.
Paula, it's always such a pleasure to talk to you. Your knowledge and wisdom in this space is paramount, and I have really enjoyed working with you on these issues. And I know that Novant Health has really been investing in some of these programs that you've been talking about today, the things that are alternatives to emergency rooms and getting kids the right care when they need it in a way that helps them stay in their communities. So thanks for joining us today, Paula. And at the heart of all these recommendations is one goal: to ensure that children are in the right place, receiving the right care at the right time. Thanks for listening.